But hello, everyone, and welcome to our webinar. Before we start today, I want to take some time to acknowledge and respect the Indigenous people and communities whose historical relationships with the land continue to this day, and on whose traditional territories all of our work does take place. So we acknowledge a debt to those here before us and recognize our responsibility as guests to respect and honor the intimate relationships Indigenous people have with this land. So, hi, my name is Yusra, and I'm a research assistant with Peach Health Ontario and the Canadian Coalition for Green Healthcare. On behalf of both, I would like to welcome you to today's webinar titled Navigating Drug Shortages, Climate Resiliency, and Operational Innovation Within Pharmacy. And I'm going to go back to the back side real quick, but I just wanted to also plug real quick. Peach is also hosting a conference upcoming in May, so May 21st, 2025. It'll be at the Royal Botanical Gardens in Hamilton. And if you're interested in coming to this, please do register if you would like to. The registration deadline is May 1st. And if you have any questions surrounding it, you can always email me as well. I will throw my email in the chat as well too if you have any questions surrounding it. But with that, yeah, welcome to our webinar. And we wanted to reiterate real quick that throughout the webinar, please use the chat function for any technical issues or any comments you may have or anything you might be experiencing throughout the webinar. And then use the Q&A function for any questions you have specifically regarding the presentation. And these are going to be the questions that our panelists will answer at the end of our webinar. We'll have a little Q&A section for them to chat with you all as well too. And with that, I'm going to pass the floor to Shaliza, who's going to introduce our panelists. I'm going to stop sharing my screen and let them start sharing theirs as well. So take it away, Shaliza.
Thank you. And while Stefanie shares her screen, I will start the introduction. So hello, everyone. It's lovely to be here today, and just want to thank the Canadian Coalition of Green Healthcare for, as usual, being an excellent partner for the Canadian Association of Pharmacy for the Environment, for which I co-chair, and we have some great speakers from the Canadian Association of Pharmacy for the Environment here today. This month is actually Pharmacy Awareness Month, so a super exciting month for all pharmacy teams across the country. CAPHE, or the Canadian Association of Pharmacy for the Environment, also has other collaborations with the coalition, including the Sustainable Prescribing Group, collaboration on adaptation of healthcare systems within heat specifically, as well as green teams. And CAPHE has a great team of pharmacy professionals working across the country in planetary health. So planetary health within pharmacy includes areas of emission reduction and pollution reduction related to pharmacy, as well as focusing on the resilience of pharmacy services to extreme weather events and other climate hazards as well. We also have partnerships with climate and health organizations like the Coalition, as well as pharmacy-specific organizations across the country. And that's basically how, through partnership, through synergy, we are able to make a great impact with the amazing teams, which you'll see a little bit of that today. So today we have an excellent presentation for you from our Canadian Association of Pharmacy for the Environment Content Committee. So we have two individuals. The first, so our two speakers today are Stefanie Black. She is the supply chain lead at CAPHE. And Stefanie has a Master's of Health Administration from the University of British Columbia. She's been a registered pharmacist for 13 years. She worked as a community pharmacist for 10 years in several BC communities. And then in 2021, Stefanie joined the BC Ministry of Health, where she is a pharmacist with the Provincial Territorial Drug Shortages Unit. In this role, she chairs a pan-Canadian multi-stakeholder team that works collaboratively to help identify, prevent, mitigate, and resolve drug shortages of national concern. So Stefanie's background in patient care drives her work in public service to boost supply chain resiliency and also improve drug accessibility for all Canadians. So we are very grateful to have Stefanie on our team. Our second pharmacist is the lead for mitigation at CAFE, climate mitigation at CAFE, and her name is Loretta Lee. She is a drug use evaluation pharmacist at the Scarborough Health Network in Toronto. Loretta as a member of the Drugs and Therapeutics Committee, Safe Medication Practice Committee, and Narcotics Oversight Committee. Loretta collaborates with other interdisciplinary professionals to evaluate medication effectiveness, develop medication use guidelines, and promote the safe and cost-effective use of medications. She's personally interested and passionate about healthcare sustainability, so she applies a planetary health lens to pharmacy system level decisions. And her current projects include IV to PO stewardship, deprescribing in the elderly, and green initiatives in the operating room. So thank you, Stefanie and Loretta.
Awesome. Thanks for the intro, Shaliza. All right. I know we already did a land acknowledgement, but I just want to acknowledge that I'm coming to you today from the territory of the Lekwungen-speaking people, known today as the Esquimalt and Songhees First Nations. So today we're going to go through and just understand some reasons for why drug shortages happen. We're going to look at the intersection between how climate can impact this. And then importantly, we're going to look at some tools for how we can actually manage drug shortages. And the focus is really going to be on collaboration and deprescribing today. All right, so why do drug shortages happen? The top 3 reasons for drug shortages are manufacturing problems, unexpected increases in demand, and shipping delays. Now, that said, unexpected increases in demand are typically the result of a competitor shortage that is due to manufacturing problems. So manufacturing really at the top. Prior to working in government, I was working as a community pharmacist, and I remember patients coming and asking, like, why is my drug short? And I had a standard answer that, it could be many things, usually due to manufacturing issue or shipping. But I've since realized that drug shortages are so complex, they can be caused by a multitude of factors. So manufacturing problems or delays can be many different things. Some examples are like filtration issues, filling issues, they detect impurities, good manufacturing practice compliance. So I'm not an expert in this area, but I can appreciate just how many things need to go right and how many checks and balances there are to make sure that drug products that Canadians receive are safe. Now, an increase in demand can be due to new drugs coming onto the market or a new indication, but it can also be due to a discontinuation or shortage of an alternative drug. And then we also look at things like changes in coverage policies, so pharmacare coverage, or a change in clinical guidelines. Now, shipping delays are one that, I would have thought would be limited to just weather, and we are going to get into that. But we've also seen shipping issues in Canada that have resulted from strikes at the Port of Montreal and the port in Vancouver as well. And then we've got shortage of raw materials ingredients. Now, this is one of the more obvious ones, but it includes more than when you're just looking at the active pharmaceutical ingredient. So there can be challenges obtaining even things like vials for the drug to go into, or the stoppers, or we've seen issues with labeling even. And another big one that has come up a couple times has been auto-injector pens for injectable drugs. And the next, for drug discontinuation, we'll be clear that the decision to produce, market, and sell drugs in Canada is made by drug companies. So we don't have a say over what drugs make it onto the Canadian market. So drug discontinuations can happen for many different reasons, including lack of profit or if there's significant challenges in accessing the active pharmaceutical ingredient. We will go into more detail on this, but it's an important note that our supply chain is very global. Pharmaceutical companies are at risk from climate-related events due to several factors. First, global nature of the sector means they're exposed to a wide range of climate-related impacts, from extreme heat to cold snaps and flooding. The nature of the sector also makes them more vulnerable to climate risks, and this is just due to the fact that there's specialized processes and there's also a regulatory environment that makes pivoting to an alternate production facility more of a challenge. And of course, as we've all experienced with COVID, pandemics can drastically change the demand for certain drugs. All right, so getting into the climate part of how there's an impact on drug shortages. I'm going to go through a few examples here. So in 2019, a processing plant's production line was stopped in drought-stricken India. And this is an example of how the climate crisis increasingly threatens the security of local, national, and international drug supply chains. In September of 2018, a company had to dial back production for 2 weeks at a facility just outside Stockholm, Sweden. This was when excessive heat and humidity endangered the manufacturing process. Hurricane Maria in Puerto Rico in 2018 shut down power to the island, and this impacted actually many different manufacturing sites, and many of these were producing drugs that are used in critical care. Flooding at a plant in North Carolina in 2024, this resulted from another hurricane, Hurricane Helene, impacted sterile injectable production. Another example of flooding that impacted drug supply was that in BC, we experienced an atmospheric river in November of 2021. This shut off the roads to and from Vancouver. Since the main distribution centers for drugs are located in Vancouver, we had to go to extraordinary measures to get drugs to other parts of the province. And this included increased air shipping, which is also impactful on the environment. Another example, a tornado in 2023 in North Carolina impacted production of several sterile injectable products used in Canada. Wildfires impact distribution routes in Canada, and now this is particularly as there's a large geographic region with limited routes. So for some areas, this can be particularly challenging if you have 1 or 2 distribution centers and that's cut off by wildfires. An important note for distribution, companies often rely on having product-specific temperature-controlled transport and storage facilities. And the other key piece is that they need on-time deliveries of hazardous chemicals and pharmaceutical products. So when you have delays in shipping during extreme weather, this can put supply at risk. So even if it reaches the final destination, if it's had a deviation throughout that, you can no longer use that drug product. All right, now I share this infographic, not for you to study it the whole time it's up on the screen, but it's just to get an understanding of the complexity of the supply chain in Canada. Now, this diagram is showing, the flow of drugs, but it also looks at contracting and procurement. It looks at regulations and funding. This is just a drug supply diagram for within Canada. So this doesn't even touch on the global complexity of the supply chain. That'd be even busier slide. Canada, we rely heavily on imports for our drug supply. And now most of the active pharmaceutical ingredients that are used for manufacturing are sourced from China and India. Now, Canada does manufacture some drugs, but we also get a significant amount of our products looking at the US and Europe. Now, my previous examples that I was giving we're looking at finished product manufacturing. But as I mentioned before, there's many components that are used in manufacturing, and these are all global as well. So an example is just the glass vials that you put your drug into come from areas with large sand mines. So then you look at things like the syringes, the stoppers, the labels, the packaging. These all have global supply chains that can be influenced by climate. All right, so if we get a drug shortage, what do we do about it? Now, regardless of how a shortage has come about, whether it's climate related or otherwise, there are a number of tools that we can use. I put communications first because this is a big one. Communications and working together is one of our main tools that we have. So sometimes shortages can be managed with just having enough information, right? So using alternate drugs is often one of the first options that pharmacists look at when dealing with a drug shortage. This might also include prioritizing certain conditions or certain patient populations for a limited supply of drug. However, there are also concerns with causing what we call a secondary shortage. So if there's not enough supply of an alternate therapy, then you can have this cascading effect of more drug shortages. Sharing inventory. Now, this happens all the time. This happens often between community pharmacies. This happens between hospitals. But this also sometimes happens interprovincially for critical drug shortages. And we particularly saw this during COVID, where there was some sharing of those drugs that were used in critical care between provinces. Now, another key mitigation option is to reflect on whether the patient even requires this drug anymore. My colleague Loretta is going to discuss deprescribing in more detail. And finally, if we really need the drug and it is a critical shortage, we may look to source that drug from another country. All right, so an example of a shortage is looking at the salbutamol inhaler shortage. So this is one that is sort of happening right now. The nebules for salbutamol, those supply shortages have been due to manufacturing disruptions, but they're also due to some increased demand from the meter dose inhaler salbutamol shortages. And those were due to, again, manufacturing disruptions. But then there's also some increased demand from just the respiratory season, and we saw some spikes in November. And there's also been some switching that has happened in hospitals, looking at nebules to the meter dose inhaler. So this to just say it's complex. There's not just one reason for why we're experiencing this shortage. Now, while this shortage wasn't due to climate change, it's a good example of how a shortage can highlight the climate impacts of certain drugs. I will say this, patients love salbutamol. It has an immediate effect. It's a terrible thing not to be able to breathe. I have asthma myself and I've experienced this, and I know how well salbutamol works. So the lack of this drug, it has an immediate impact. So there's increased respiratory distress. This may lead to increased emergency room visits. And then this puts strain on pharmacy operations as well. So having to manage, the patient anxiety of not being able to breathe, looking at finding alternative therapies for patients. When we were discussing, switching from nebules to the meter dose inhalers at our Pan-Canadian group, many of the provincial territorial hospitals had implemented a switch, but then had reverted back due to environmental impacts on meter dose inhalers. Either way, it's challenging from an operations perspective, particularly within hospitals, to switch protocols over to a completely different dosage form. Now, recognizing the potential impact on patients, the salbutamol shortage was declared a Tier 3 shortage on January 17th, 2025. And a Tier 3 shortage is one that has the greatest potential impact on Canada's drug supply and healthcare system. We look at medical necessity, low availability of alternative supplies, ingredients, or therapies to help determine the degree of impact. Now, part of the mitigation strategy was to provide guidance and communications. Remember, I was talking about communications being the key thing. And this was to help prevent panic and hoarding like was seen during the early days of the pandemic. And the Canadian Pharmacists Association, who was a member of the committee that helped assign the drug to a Tier 3 status, they worked with MedSask to develop guidance on best practices related to salbutamol. And before I go to the next slide, I will say, supply is still available. It's a little bit constrained, but we are monitoring it closely, and supply is improving. Now, why am I talking about salbutamol? I feel like this has been a hot topic, and hopefully you have seen this infographic before, looking at the impacts of just one aerosol inhaler, depends on the type, but it can have the same carbon footprint as driving up to 170 kilometers in a gas car. So, of course, when this shortage happens, one key area that the various parties focused on was appropriate use of inhalers. This is an opportunity to look at, can we optimize therapy for asthma and COPD, which may include changing or adding an inhaler, which would reduce the use of salbutamol. Right. The other thing is, could we switch to a dry powder inhaler that has less of a carbon footprint? Now, we acknowledge that the dry powder inhalers in this space, the salbutamol discus, and there's also terbutaline, they're not going to be able to cover the entire market, just given how highly used the salbutamol meter dose inhalers are. But we did engage with the manufacturers of these products so that they were in the conversation. They knew about the shortage situation so that they could actually monitor and forecast for any of those increases in demand and hopefully support patients if they were deciding to switch to one of those therapies. And I'll say this, while drug shortages are never desired, the hope is that for some of them, it can create an opportunity to optimize a patient's therapy. So next I want to talk about collaboration. I'm going to be speaking at this more from the higher level, government level. So for the federal, provincial, and territorial drug shortages teams, we have the Provincial Territorial Drug Shortages Task Team. I know that's a very long acronym, PTDSTT. This focuses specifically on drug shortage issues, including pricing considerations, and generally goes, drug by drug to help mitigate these. We also have the Health Canada Health Product Shortages Directorate. They're really heavily involved with our team. Their role is they are the regulators. So they regulate and apply certain tools for drug shortage management. Tier assignment committee. So I mentioned this before that you have a committee that will make a decision about whether something can be escalated to what we call that tier 3 status. And the membership of this really depends. It changes based on the clinical expertise that's needed. So there's a few usual partners that are there, and then you get the clinical experts in to give you all of the good stuff about, oftentimes it's off-label uses that make it so important. And then we have the multi-stakeholder steering committee on drug shortages. And this is more of a strategic body that looks at drug shortage policy. The representation here is a wide range. So this includes federal, provincial, and territorial governments, but industry also sits at this table. We have healthcare professional associations that are there, and we have patient advocacy groups. So it's a really good forum for helping to be all on the same page and come up with work plans to help prevent and shortages and improve the resiliency of Canada's drug supply chain. There are also supply chain and drug shortages experts within hospitals. There's a lot more than just what I've talked about here. There's teams of people, lots who are dealing with drug shortages, and they may have connections directly with distributors and manufacturers. I will let Loretta speak a little bit more to, supply chain teams and what happens at the hospital level. And with that, I'll pass it over to my colleague, Loretta.
Thank you, Stefanie. I'm sure, Stefanie and I can talk about drug shortages on and on and on because it just seems to be a never-ending thing. And as a drug use evaluation pharmacist, managing drug shortages is a big part of my job. So when you look at the statistics, there were over 3,000 drug shortages that were reported in year 2023 to 2024. It was a 4, and the average duration of back orders lasted for about 3 months. And out of that 3,000 drug shortages, actually 1 out of 10 of them lasted over a year. So you can imagine how much impact that is on a pharmacy operational level. A lot of those actually involved high impact risk items. What that means is that there's no alternate source or brand in Canada, and the absence of the product may result in some sort of patient harm. So either alteration of the course of their disease because of lack of medication, or inability to perform medically necessary tests and procedures. So because I come from a hospital background, so on average, I would think that a hospital would be dealing with about 30 to 40 back ordered items every single day that sort of require some action on the pharmacy operational level. So it could be something as simple as just a redistribution of stock, or changes in inventory level. It could mean something that we need to compound or batch in-house, or it could be something as big as, requiring a rebuild of drugs in the clinical information system, or perhaps even the need to revise our order sets in order to guide alternate therapy. So the bottom line is that, drug shortages are very disruptive to pharmacy operations, and it can also lead to potential patient harm. Next slide. So how does a pharmacy respond to drug shortages? So there's two perspectives that we bring in. First is the logistical perspective. So meaning change in the workflow, it could mean change in procedures, stock levels. I'm very fortunate that I have a pharmacy inventory technician who works alongside with me to take care of all that. And then there's the clinical aspect of it, which is often when a pharmacist comes into play, because they have the therapeutic knowledge to do the clinical assessment. So gathering information, what is on back order, how long it's going to be, who is impacted, who are the end users, and what education needs or communication that needs to be disseminated about changes. So you would notice throughout my presentation, we have a green leaf icon. So those are opportunities to consider or implement environmental sustainability. So a big part of it is through our evaluation process, which is the most time that we usually spend on when we manage back orders, because that's when we have to look at all the logistical challenges, economic ramifications, and also what therapeutic alternatives there are, what options there are to manage the drug shortage. Next slide. So there's a few things that we would implement, either active procurement or stock management, deprescribing and therapeutic interchange. Stefanie mentioned previously the importance of communication and collaboration. And then last but not least, some ethical considerations that we want to mention. Next. So when it comes to active procurement and stock management, a lot of hospitals may have what they call a critical or essential medication list. So these lists are usually adopted from Health Canada or by the World Health Organization. It's just a tool to internally control optimal stock levels in the pharmacy. So we have our own criteria in the hospital, just looking at what are the sole source items. And not only that, but they also have to be life-saving drugs. So meaning critical care drugs or emergency resuscitation medications, antibiotics, things like that, which are considered life-saving. And then we also look at historical history of back orders. So if a certain drug, usually it's because it's sole source, it may be more at risk of back order. We look at that trend and try to adjust our inventory level. So that means adjusting the optimal inventory. It could mean a minimum level or an optimal level by setting the PAR in our inventory system. Certain things we can do is just a redistribution of the stock. And so instead of, stockpiling or going straight to ordering more, sometimes just a shoveling of your stock can get you through the drug shortage period without ordering extras. Some hospitals, they use analytics or what they call predicted analytics to really look into how inventory is moved in and out of the pharmacy. Um, but that is something that is very labor intensive and requires a lot of time. So simply just simple predictions, just based on monitoring of market trends, can also help. And of course, sometimes back orders would trigger you to look at practice changes. So I'll provide examples in the next slide. Next. So for example, rocuronium is still a current back order. There's a shortage of multiple brands. So when we see that, we would advise our teams just to look out for a brand that is not on back order and maybe try to have a bit of buffer. Same thing with neostigmine that was on back order last year. There were multiple strengths that were on back order. So then we would look out for the strength that is available. And then what we learned from the dopamine bags that went on back order is that we notice it's used very not as much as before, because the clinicians are preferring dobutamine over dopamine. So instead of stocking like 20 bags in your hospital, you can certainly cut down your stock to just maybe 10 bags and avoid, the waste and the extra deliveries and ordering and all the carbon footprint that is associated with it. Next slide. So there are strategies to further manage back orders. I have listed 3 of them. They all have one thing in common, which is to reduce usage in some way, because it might be an ad hoc, decision just to order more when there's a shortage, but that's not something that always works. So we need something that is more sustainable when there's limited resources. So deprescribing is something that we often consider. It's a planned and supervised process of dose reduction or stopping the medication. So it's not like, you just cold turkey someone, get them off the drug. That's not what it's about. It's about doing evidence-based deprescribing in a monitored fashion. So it could mean eliminating the drug if that is an option, or it could just mean tapering or dose reduction if that's feasible. The second thing we would try to consider is therapeutic interchange. So that means you would substitute a medication with another chemically equivalent medication. And this is often done with pre-approved policies within a hospital. And then the third is restricted use. So it's pretty self-explanatory. It means you, instead of opening the drug to all indications, you just want to restrict to the 1 or 2 indications that you definitely need this drug for when there's no other option. Next slide. So these are examples of each of those strategies. So for example, with the nitrofurantoin or macrobid shortage, we were able to manage with the short-acting form of nitrofurantoin. So pharmacists would be able to substitute that without notifying the prescriber. It's a straight therapeutic interchange. Cipro IV was also recently on back order. So we have IV to PO a therapeutic interchange or substitution for people for patients who meet the criteria, of course. And then we also implemented restricted use. So we were only restricting it to patients who cannot tolerate oral Cipro or who cannot be on an alternative antibiotic, most likely because of resistant organisms. The aminophylline shortage was pretty interesting because it's used for reversal of dipyramidal side effects in cardiac stress tests. So when we looked at the guidelines, there's actually not a lot of alternatives that are available in Canada. But one thing I find interesting was caffeine was recommended as one of the recommendations for mild cases. So for mild cases, people who just have mild symptoms, they don't need to be monitored. They can certainly be sent down for a cup of coffee. And I believe that strategy is still being utilized up till now because it's basically a non-pharmacological strategy, right? And certainly it's about deprescribing. And then for the patients who have a bit more symptoms, we start with a dose reduction. So instead of the full dose, we give 50% of the dose, and then you just repeat as needed. I'm not concerned about, them not getting the full dose as long as, it's able to reverse some of their symptoms. Next slide. So this was mentioned by Stefanie, how drug shortage is very complex and it requires multi-stakeholder approach. Stefanie already mentioned, the government level, Health Canada level, on the industry, how they work nationally to manage back orders. And then there's the regional level. So hospitals, drug companies, and distributors all have to coordinate effort. And then at the local level, it could mean like a multiple hospital sites. It could mean the multidisciplinary team within hospitals and also in the community, as well as pharmacists and patients who are also involved. So the next few slides would illustrate an example of different collaboration at different levels. The first example relates to the critical care drug shortage during COVID-19. So because there was increased demand of critical care drugs used to treat COVID, it led to some drug shortages. But Health Canada had a critical drug reserve, which is at the federal government level that was established to ensure appropriate stock rotation and a safety stock of drugs used in critical care, and those are the drugs that were listed. Tocilizumab is a drug that is used for the treatment of COVID, and of course, not surprisingly, it led to, the increased demand led to a shortage. So this is where we need provincial or a coherent approach from the province in order to guide the fair distribution of drugs. And this is from the Ontario Science Table, for example, guidelines for the treatment of COVID. And this is not the first version. This was, the modified versions as we learned through COVID. But you would note that there is a section on recommendations for drug shortage situations. So it would tell you what is the first line of treatment, what's the second line, what's the third line. So drug shortages is part of the recommendation when it comes to these guidelines. Unfortunately, next slide. It was short. There was limited allocation from the drug company, so we basically had to have a dose cap for all patients. So instead of milligram per kilo dosing, we just capped it at 400 milligrams for all patients, and we had to restrict it to be prescribed only by infectious diseases. All our hospitals, we really came together to report our quantities on hand. Because we're a large hospital in Toronto where COVID really hit hard, none of the GTA hospitals basically had enough tocilizumab. And I remember we had to call, London Health Sciences, which is 4 hours away for a dose, or even Sudbury, which is 6 hours away for a tocilizumab dose for our patients. And even that was not enough. So we were one of the hospitals that had to introduce a lottery system, meaning that, we would put patients who meet inclusion criteria into a pool. And because we don't have enough doses for all the patients, we would have a computerized draw to determine who gets the dose available. So it was a hard decision to come to that point, but it was probably the only way to ensure fair allocation of a scarce resource at that time. And then much later, Sarilumab and baricitinib became available for COVID treatment, so that kind of eased the tocilizumab shortage. Next slide. The pantoprazole shortage is really interesting. It started last summer in June 2024. Again, this illustrates another example of a huge collaboration. We know that pantoprazole IV is a drug that's being overused, but we never had a chance to know what to do about it until this shortage hit us. It really gave us reflection on how we should change our practice to minimize use. So CSHP and the Canadian Association of Gastroenterologists came together to come up with some recommendations, and these were fully supported by the GI team. They really set good example on how to drive practice changes. And you would notice they, of course, recommend PO options or enteral options whenever possible. These tie in nicely with choosing wisely climate conscious recommendations. And the shortage was really long enough. It's going to hopefully resolve by the end of this month, but it was long enough to allow practitioners to adapt to their practice changes. Next slide. So what the guidelines recommend was IV to PO changes if patients able to tolerate. We also restricted IV pantoprazole to patients with active GI bleeds with high risk ulcers only. Of course, that was defined in the recommendation of what is considered high bleeding risk. And then we also limited pre-endoscopy use of IV pantoprazole. Even if patients are NPO, they can certainly take tablets with sips of water. And then we looked at the evidence. So it was concluded in the studies that intermittent doses are actually as efficacious as continuous infusions. So we were trying to, up till now, we're trying to use intermittent doses in place of continuous infusions just to reduce the use of IV pantoprazole. Next slide. So this is an example. We tried to utilize our clinical information system in order to remind prescribers what the alternatives are when IV pantoprazole is ordered. We can also pull reports for pharmacists. So you would notice the report will tell you who's on IV pantoprazole and what kind of diet they are on. So basically, if someone is on a clear fluid diet, on an adult soft diet, regular diet, those are the patients who would be prioritized because they certainly do not need pantoprazole IV, and they can be stepped down to PO. Next is an example of collaboration on the nursing and local hospital level. Because there was a epinephrine pre-filled syringe shortage, so we had to prepare the kits because there was no alternate source that we could use. But the kits come in are made from ampules that are in a different concentration than the pre-filled syringe, and therefore we had to be very clear about the instructions provided to the nurses, because these medications are used in emergency resuscitation situations. Basically, nurses don't have the time to look through, whatever resources to give these medications. And epinephrine can lead to increased risk of errors when it's given inadvertently. So we don't want to delay treatment in these situations. So clear instructions are definitely needed with all the supplies provided so that they don't have to scramble around and look for things. Later on, there was a US labeled product that was introduced and imported by Health Canada. But we noticed that the syringe is a little different than the Canadian product. So again, nurses, especially those on the code teams, would need to be fully trained on how to use the new product, and they had training through mock codes so that they can practice. We provide a placebo supply so that they can also practice during their training. So again, all of this really highlights the interdisciplinary collaboration at different levels. Next, just wanted to go over some of the ethical considerations because we want to emphasize that however way we manage, there's different ways to manage drug shortages, but they must be guided by ethical principles. So, for example, of course, we first of all want to put the patient's best interest first, making all efforts to ensure continuity of care of their therapy. Of course, we do no harm. So that's non-maleficence. There's also other principles that are closely linked to planetary health. So, for example, justice is one of them. Justice is about making fair decisions when resources are limited. And so everyone needs to contribute. It's not my recommendation on what to do, but rather everybody needs to contribute to rational prescribing and conservation. So it's a multidisciplinary effort. The other thing is stewardship, which is about taking good care of your resources and also responsible management of the shared resources. So as I mentioned, it's often that we tend to stockpile when there's a drug shortage, but that could be minimized when we do the appropriate assessment. So just requesting what you need and adjusting inventory requirements based on the duration of the back order. And of course, that has to align with the company's timelines. And then there's the operational strategies of deprescribing, therapeutic interchange that we mentioned that could definitely help with your appropriate assessment. In addition, it's the drug manufacturers and distributors' responsibility as well to make sure that the amounts are allocated fairly to avoid sites from hoarding. And then I noticed, like when we're switching from one product to the other, our experience is that it often comes with waste, and then things end up expired. So again, the goal of the stewardship is to really take waste and cost into consideration and try to minimize that within the healthcare system. Trust and utility is important to foster and maintain public, patient, and healthcare provider confidence. And it is a collaborative effort to ensure, Canadians have equal access to the drugs that they need. Unfortunately, in a drug shortage situation, we just don't have enough for everybody, and that's the reality. But it is important to prioritize and maximize the benefit to your most vulnerable patients who are in need of the medication. Next. So just to conclude our presentation today, there are a lot of reasons for drug shortages, and sometimes we don't realize, but it is a fact that climate change is certainly one of the reasons for the cause. Drug shortage requires multi-stakeholder collaboration at different levels, national, regional, and local levels. There are strategies for us to reduce use, including deprescribing, therapeutic intervention, and restricted use. These are strategies that we can implement to respond to drug shortages and also potentially in the long run for practice changes. And we need to apply ethical principles of justice and stewardship in order to ensure sustainable and equitable health outcomes for all. So that's all I have. Thank you so much. I'll pass on the time for questions and answers.
Perfect. Thank you so much, Stephanie and Loretta, on your amazing presentations today. With that, I put a note out in the general chat as well too, but if you have any questions for our wonderful panelists, please be sure to put them into the Q&A function of the webinar. I'm just going to get a slide going as well too that kind of just reinstates that as well. And just resume. For Swasti, yes, we will be posting up the slides after the presentation today. So all attendees will get an email with the slides link, the presentation like viewing link, and then also a feedback form to share with us. I also just realized when I'm sharing screen, I can't see the Q&A section. Oh, actually, no, I can. It's right here. Great. Michaela has a question. She starts with saying, thank you for the great presentations. And she's asking, how does Canada rank in terms of supply chain interruptions for pharmaceutical companies or for pharmaceuticals compared to the rest of the world? Are we one of the worst?
So I'll take that one. Number one, it is a challenge to compare between countries because there are different rules for number one, how a drug shortage is defined. So in Canada, we define it as when a company cannot meet its orders in full on time. And then differences in reporting. So we have a regulation in Canada that requires what we call market authorization holders, but manufacturers is the other term, to any anticipated or actual drug shortage needs to get reported. So difficult to compare. That said, because the supply chain is global, you are looking at shortages across the globe. I'm going to pull up another one of my slide decks because I was just recently giving a talk and it was talking about, so in 2024, there was an article in JAMA called The Differences in Drug Shortages in the US and Canada. And researchers were looking at how often supply chain issues resulted in actual drug shortages. And this was just comparing the US and Canada, so not all of the countries. But of the 104 reported drug supply chain issues that were in the US and Canada between 2017 and 2021, within 12 months, 49% in the US were associated with a drug shortage and 34% in Canada. So drug-related reports of supply chain issues were 40% less likely to result in meaningful drug shortages in Canada compared with the US. And the researchers also looked at whether this was the case before and after COVID, and the results were the same. And now a key reason that they attributed to this success was the multi-partner approach that Canada takes, which is what Loretta and I were talking about, where we have industry, healthcare professional associations, and governments, as well as patients all coming together towards a common goal.
Yeah, I just want to add that, I find Canada is unique in a sense that Canada is just large. like just to logistically, just to, you know, redistribute your stock or to move drugs from one place to the other is a logistical challenge on its own. And also, you know, Health Canada certainly has a lot of strict regulations when they do their inspections and how they govern the industry. So that also is a factor related to the cause of drug shortages in Canada.
Perfect. Thank you. We have a couple more questions that have just come in. To be cognizant of time, I know we only have 4 minutes technically left on it, but Stephanie and Loretta, are you okay to stay a couple extra minutes to answer questions?
Mhm.
Perfect. Okay. I'll ask the first one then. So this one comes in from Caitlin, who is asking, when creating emergency supply lists, how can the environment be considered to balance the true need versus the effects on the planet?
Ooh. That's a tough
Yeah,
one, Loretta. Do you?
I know. One thing is the references from Health Canada or the WHO is certainly um, the guideline or the framework. But if you look at them, you know, there's hundreds of pages. So of course we cannot go by that list. And so the first thing is to really trim down the list based on your organization or your hospital's need. And that's why I was mentioning hospitals may have their own list instead of going by the, you know, full list. So that's one thing. The other thing is really through usage, because usage is site specific. Even within the same hospital, if you have different sites may have different usage depending on what programs you have. So from there, you would have to assess your usage and determine, are you going to keep a 1 month supply versus a 2 month supply, and then adjusting your inventory par levels from there.
And then I'll speak to more of the national level. So there is this critical and vulnerable to drug list, which has recently been developed, that's on Health Canada's website. The inputs into this were primarily looking at, you know, the clinical risk of not having a drug. So ranking, scoring them based on their clinical importance. And then there was a bunch of inputs looking at vulnerability to shortage. So, you know, whether it's been in shortage before, is it sole source, is it sterile injectable, all of those different things. I will say the data that is looking at the environmental impact would be very difficult with our current grasp on the data to input into that to inform the list. But how you use that list, to Loretta's point, is where I think we could have more benefit. So these lists have been developed for a variety of different reasons, but again, having people figure out, like, okay, if these are critical and vulnerable to shortage, what's the most appropriate stock to keep on hand, making sure that it's within expiry date, limiting waste while also having enough to be able to mitigate a shortage. So it's not, as far as I'm aware, being used in the creation of the list, but I think the key part is how you use it.
Wonderful. Thank you guys. We have one more question here. I'm gonna just read it out. So it's I remember that when there were key pharma interruptions during the hurricane season in Puerto Rico, that the US hospitals were talking about setting up manufacturing of certain drugs instead of relying on the private sector. Do you know if this is still in discussion?
Yeah, so there is actually a bit of this happening. So there's a company, it's called Civica RX in the US. So this is not in Canada, but they are looking, and I don't know exactly the status of it, but they are fully like a company, and their focus is on manufacturing drugs for hospitals primarily, like the sterile injectables, because that was what was impacted the most during the hurricanes. So I don't know an update on their scope, but it absolutely has taken effect since those conversations. And I can
Perfect.
put it in here. It's called Civ. There you go.
I'm going to I think you have to change the setting on that to everyone, because right now it just delivered to hosts and panelists.
Oh, that's not helpful.
Also, it does not let me ask questions since I guess I'm a host on here, but I did have a question as well too. So I'm from a global health background, and within that, we talk a lot about like policy and analyzing ways to make it more effective. And so I had a question regarding everything we spoke about today, and like, are there any policies or policy implementations you think that can help prevent future shortages, especially within the climate change aspect of things? Or are there any recommendations that are already out there in the policy world?
It's the $1 million question, isn't it?
Yeah.
I think it's such a difficult one to answer, and the reason why drug shortages are why there's so many people working on it is that it doesn't have an easy one solution. So there's a lot of suggestions, one of which is like domestic manufacturing always comes up. But because the supply chains are so global in nature, it would be difficult to have entirely domestic production. So you mentioned, you remember from the talk, I was saying like most of our active pharmaceutical ingredients are coming from China and India. So even if you were to domestically produce drugs in Canada, you're still reliant on a global supply chain. Lots of the reasons for drug shortages have been due to consolidation within the supply chain, which then adds to the vulnerability. And a lot of this is driven by cost. So the issue is that just paying more for drugs doesn't necessarily mean that you don't experience supply chain issues. So it's very multifaceted. I wish that I had a policy solution that we could just implement.
Truly. All right. Thank you so much. Would you both be comfortable with sharing your emails with attendees as well to their questions after this talk as well?
Yeah.
Okay, perfect. I'll add that to our slides. For sake of time, we can, I guess, start wrapping it up here. So once again, I would like to share my sincerity and thank the hosts for being such wonderful panelists today and spoke so wonderfully as well too. So round of applause for them. I know no one can have their audios on or anything right now, but I hope everyone's silently clapping. Um, but yeah, thank you so much for joining us today. And like I mentioned earlier as well too, all attendees will get a email shortly after with a viewable link to slides, be able to view the actual webinar as well too, for those who maybe had to like cut in or join late or had to leave early. And yeah, that's kind of it. So everyone have a great rest of your day and thank you so much for joining us.
Thanks for having us.
Of course. All right. Bye.